Listen to that. It's either front or back. I don't think that's what the light.
Check. We're live on YouTube channel.
Forward, yeah, because it's whipping around.
Is that an improvement?
Seems like it's not quite as bad.
Yeah, it's better.
You want to lower this? Yeah, I'm going to put this up. Base will be enough space.
Oh, yeah. Let me,
Huh?
yeah.
Okay, good. All right, that's one idea. Three the button.
Yeah.
It
Perfect.
seems to be a little better. Good. Yeah. Okay.
Please. Okay. Thank you. This is just the focus of the short term.
No.
Oh, did I disconnect? Yeah, I'm so sorry.
Yeah.
Yeah, that's great. Satisfactory? Yeah.
Thank you so much.
Great.
Thanks, Arun.
There's no official.
Check. Okay. Finally, we were able to get everything put up together. I think we can get started with the program. My name is Dr. Palniyappan Chidambaram, and I have the honor and pleasure to serve as the president of the Nagaratha Physicians of North America and International. And I would like to welcome all of you for this program today, the CME event at our NSNA retreat. And it is a pleasure and privilege to get started with this program. This is the first program the NSNA retreat is starting with, so it's nice. And thank you for being patient. So we are backed up a little bit. We've got the audio, video, everything set up. So we have 3 fine speakers today, and this CME program is being led by Dr. Arun. Dr. Arun, he is from New Jersey. He's a geriatrician. You all know him. And then we have fine speakers, 3 speakers, Arun Narayanan and Dr. Palniyappan, and also Kumar Nathan. I will give the podium to Dr. Arun to introduce the speakers, and we will get this CME program officially started. So this program is being live web streamed on YouTube through NPNA TV channel, and the recording should be available for anyone to see this in future. I would like to welcome you all on behalf of NPNA, Nagaratha Physicians of North America and International. We are an international Nagaratha Physicians organization. Welcome you all again. I'm going to give the hand over the speaker to Arun. Arun, welcome. Take over.
Thanks, Dr. Palniyappan. Welcome, everybody. And thanks for waiting. I know we had small glitches. We were supposed to be in a different room, but anyhow, we are here finally starting. Good. This YouTube and Zoom focusing is just started only yesterday. because a couple of people who said they're not coming today until evening, so we have this arranged for them also. Our first speaker for the day is Dr. Arun Narayanan, going to speak about contemporary management of atrial fibrillation. Dr. Arun Narayanan is an associate professor of medicine and a cardiac electrophysiologist at the University of Texas Medical Branch, UTMB in Galveston. Some of his credentials, he finished his clinical cardiac electrophysiology fellowship at the Tufts Medical Center, Boston, Massachusetts. And before that, he had his cardiovascular disease fellowship at the New York Presbyterian Brooklyn Methodist Brooklyn Hospital, New York. And prior to that, he completed his internal medical residency at the University of Texas Health Sciences in Houston, Texas. And he is originally from the combined program, I think, the Manipal University, American University of Antigua Medical School. And I'll welcome, without further ado, with Arun Narayanan. Thank you.
Hi everyone, I'm Arun. I want to start off by saying that this is very exciting, and I'm glad that we were able to organize this. I want to thank our uncle, NPNA-NHC for giving me the opportunity to speak here, and I want to thank all of you for being here as well. So I'm going to be talking about the management of AFib. I tried to tailor the talk for a few of us who may know AFib well and a few of us who may not know it as well. So what is AFib? So AFib is the most common type of heart arrhythmia. A arrhythmia is when your heart either beats too slow or too fast or in an irregular way. As you can see, the heart on the left, the top two chambers initially beat, and that comes down into the bottom. This is how a normal heart beats. The heart on the right is an AFib, where the top two chambers of the heart are beating chaotically, very irregularly. And this can cause the heart to move too slow or too fast. So let's get into the epidemiology of AFib. This is from the CDC this year. It's estimated that 12 million people in the United States will have AFib in 2030. In 2019, about 200,000 people died of AFib. And of those, about 25,000 were indicated as the primary cause. People of European descent are more likely to have AFib than African Americans. Observational studies have shown among Asians, there's actually a lower incidence of AFib, which is a little unexpected because across the board, when you look at hypertension, high cholesterol, and diabetes, Asians and Indians specifically have a higher rate when compared to other Americans in the States, but our rate of AFib is actually lower, and it's thought to be because we are smaller in general, and our atriums are smaller, and so it takes a lot more injury and time for the atria to dilate and cause AFib. There have been more than 500,000 hospitalizations for AFib as a primary diagnosis each year. And as I said, up to 200,000 people die each year as well. And the rate of this has been increasing over the past 2 decades. This data is from the Olmsted County study between 1980 and 2000. And as you can see, the overall incidence of AFib has increased over this time. And this trend has continued over the last 20 years as well. This data from a cohort study of over 8,000 patients shows the risk of stroke related to the cardiac condition that you have. So high blood pressure, other forms of heart disease, heart failure. There is an increased risk of stroke, but not as much as an AFib. When looking at outcomes in AFib, you're twice as likely to die if you have AFib. You have a more than 5-time increase in stroke. And those strokes are worse than the everyday stroke because it's due to a embolism that comes from the left upper chamber of the heart and leads to a stroke in the brain. There are more frequent hospital stays, the quality of life is worse, and there's a higher incidence of having heart failure as well. This is a chart comparing the US population to the population with AFib by age group. You can clearly see that as we get older, the incidence of AFib increases with the highest percentage in our 80s or so. It is predicted within the next 10 years that a quarter of US adults will develop AFib, which is an unbelievable number. As the incidence of AFib has increased, the interest in AFib has grown accordingly as well. You can see in the last 10 years, the number of Google inputs for AFib, but it's still a big unknown amongst the population as a whole. As you can see, compared to Kim Kardashian, AFib is something that people have no idea about it, and this is a big problem. So I want to harp on this again. Why is this important? So AFib, you're more likely to die of heart failure, stroke. About 1/3 of all strokes are from AFib. And 10 to 40% of AFib patients have to be hospitalized every year. There's a stark decrease in quality of life in these patients. And it can have an impact of the squeeze of the left lower chamber of your heart. So when we talk about heart failure, we're talking about the heart function of your heart, and having AFib can impact that as well. So what are the goals of therapy for AFib? It's twofold. One, we want to decrease the incidence of stroke. Stroke is one of the most unfortunate things that can happen, and it's something that we want to try to prevent in any way possible. And then we want to improve how patients feel. We want to improve in terms of having heart failure, having chest pain, shortness of breath, and such. So the primary mode of therapy to reduce stroke is oral anticoagulation, or being on a blood thinner. In terms of alleviation of symptoms, there are two strategies. It's to control the heart rate, meaning try to bring the heart rate down when you're in AFib. And the other strategy is to try to keep patients out of AFib altogether. And the way we do this is with antiarrhythmics, which are drugs which are able to keep patients out of AFib, and with ablation as well. And we'll talk more about that. So here, this is an echocardiogram. When I see this, this is a very scary image for a EP, for a cardiologist. You can see this is the left upper chamber and the left lower chamber of the heart. And there's a pouch that comes off of the left upper chamber of the heart. And inside that pouch, this is, I can come to it here, this is a clot. This is a large clot in the left upper chamber of the heart that you see when patients have AFib. And if that clot leaves the heart, in all likelihood, it will go to the brain and cause a massive stroke. That's why oral anticoagulation is very critical in terms of AFib management. So, how do we decide who should get anticoagulation? There have been multiple clinical scores that have been developed in small cohort studies and have been validated in larger populations. And the introduction of these scores has helped improve our decision making in terms of deciding who should be on anticoagulation. The primary score that's used now is the CHADS-2 VAS score, which looks at the current conditions that the patient has to develop a likelihood of having stroke within 1 year. This includes having heart failure, hypertension, age, having diabetes, if you've had a stroke in the past, any sort of coronary artery disease, and if you're a male or a female. The individual risk factors do not contribute equally. As you can see the score, there are some that have 1, others that have 2. If you've had a prior stroke, or if you're over the age of 75, you're at even higher chance of having stroke with AFib. As the CHADS-2 VAS score increases, the risk of stroke in 1 year also increases. And our current guidelines indicate that anyone with a score of 2 should be started on oral anticoagulation because they have more than a 2% risk of stroke in 1 year. And this is important to note that it's cumulative over time. And so if you stay off anticoagulation with a CHADS-2 VAS of 2, in 5 years, you've developed a 10% risk of stroke over that time, which is very high. There have been multiple studies starting with Coumadin or warfarin to assess the efficacy of anticoagulation. This was an analysis of smaller studies that showed a reduction of stroke by almost 2/3 and a reduction in death by almost 1/4 in patients who are on anticoagulation as compared to patients who are not. So it does work. Now, the problem with Coumadin, which is something that we don't use as often anymore, is that the window of therapy is very narrow. And what I mean by that is if you're not on enough, you have a higher chance of stroke, but if you're on too much, you have a higher chance to bleed. And this can be complicated. Stroke is something you want to avoid, but a bleed is also something that you want to avoid. And so we go by a lab called INR, which allows us to identify how thin the blood actually is when you're on Coumadin with a goal of 2 to 3. You can see in this chart how the window is very narrow. So obviously that's not ideal. You have to get lab draws often, initially every few days and then every few weeks. And then you have to adjust your dose often. And then there are also things that you eat that can also interact with this as well. And so it's not ideal at all. But what is the ideal anticoagulant? One that you don't have to monitor, one that the dosing is fixed, one where there's no interaction with food, and one that the onset is immediate. And we are lucky that in the last 10 to 20 years that we have been able to find these anticoagulants. And so this is Coumadin, which as I said, we don't use as often anymore. But now we have newer oral anticoagulants or novel oral anticoagulants like Eliquis and Xarelto, which allow us to treat patients without having to worry about how thin the blood is and without having to monitor it as well. So this is a comparison of all these anticoagulants when compared to Coumadin and the trials that were done. And what it showed was that both apixaban, which is Eliquis, the bigatran showed a reduction in stroke when compared to Coumadin, and apixaban and edoxaban showed a reduction in bleeding. So main points for anticoagulation, as I said, Eliquis or apixaban and dabigatran showed a reduction in stroke when compared to Coumadin. The majority of stroke risk reduction in all these anticoagulants was driven by a reduction in hemorrhagic stroke, which means stroke that comes from when you bleed, which is an indicator of having blood that is too thin. And so in general, all these anticoagulants are pretty good at being able to prevent clot in the atrium of the heart, but the risk exists in terms of if it's going to cause the bleed or not. This is an important note or caveat. If a patient has a mechanical heart valve or has valvular AFib, which means AFib that's from a stenosed valve in the heart, then these patients have to be on Coumadin. And you would ask why, which is a very fair question. And the reason is because we don't have the studies yet. They're currently being conducted to evaluate these newer oral anticoagulation agents in these groups. So if they have a mechanical heart valve or if they have a stenosis valve that caused the AFib, they have to be on inhibitor. Now, as we looked at the CHADS-2 VAS score, you also have to evaluate the risk of bleeding. It's very critical to assess in these patients. But if you go through them, the first thing that you would say is that it looks the same as the CHADS-2 VAS score: hypertension, stroke, if they're old. And that's what makes managing these patients complicated, is that the things that give you a higher risk to have an embolic stroke are the same things that give you a higher risk to bleed as well. That's why it can be challenging. And so how do we manage this? What if you have a patient who cannot be on an oral anticoagulant? So we have devices that we've been implanting probably for the last 10 years or so, which are able to go and close the pouch, if you recall on the echocardiogram I showed you, to prevent blood flow within that pouch, to prevent clots. These are called closure devices, or left atrial appendage closure devices, and we have a few out there. These are all a few examples. One of the most common ones is called the Watchman, which is basically a little parachute that we implant within that pouch in the left upper chamber of the heart. There have been 2 large randomized studies, Protect AF and Prevail, which showed a non-inferiority to Coumadin. Now, it's important that people understand that the indication for these devices is not as wide as you would expect. If patients are able to tolerate an oral anticoagulant, then they should be on an oral anticoagulant. As I said, we've only been implanting these devices for 10 years or so. We don't know what the long-term outcomes of these. And so it should be left for patients who are absolutely unable to tolerate anticoagulation. And it should be done at places where they have expertise in implanting these devices, and it should be done by operators who have done this often. So we have done our best to reduce the risk of stroke. That's great. That's excellent. Now we have to improve how the patient is feeling. So as I said, the 2 strategies are to control the rate or to keep patients out of AFib. To keep them out of AFib, we can use antiarrhythmics or we can do ablation. So how do we classify AFib? AFib is classified in 4 categories. One is paroxysmal AFib, which means that they've had AFib for under a week and they have spontaneously converted out of AFib. Then it's persistent AFib, meaning that it's lasted longer than a week. Then long-standing persistent, which means that it's lasted longer than a year. And then it's permanent AFib, which means that they're always in AFib with no plan to attempt to try to get them out of it. And the reason this is important is because our strategies in terms of how to manage these patients is dependent on what group they fall in. So when we try to rate control patients, the goal is to improve the heart rate. When you're in AFib, as I said, the left upper chambers of the heart are chaotic. They're going very, very, very fast. And those impulses then go down into the lower chambers of the heart and cause the bottom of the heart to go fast. And so when people say they feel bad, either they're having a hard time to breathe, unable to exercise as well, having chest pain, dizziness, it's all because the bottom of the heart is going fast. So if you can imagine, if we're able to control the rate of the bottom of the heart, it'll improve how they feel, ideally. So this is, in general, the initial strategy: try to control the rate. There are a few options of this, and it depends on the patient's heart function. You can use AV nodal blocking agents like a calcium channel blocker or a beta blocker to help to control the heart rate. Within these, there are actually quite a few, but these are our main options. Now, there are some patients where you are unable to control the heart rate despite the medications that you use. One option is what's called AV nodal ablation. Now, the AV node is a piece of specialized tissue that that sits in between the upper and lower chambers of the heart. And that allows the communication of the impulses from the upper into the bottom chambers. So we actually go and ablate this. We actually go and burn your AV node to prevent any communication from the top into the bottom. So if you can imagine, if you have AFib, it wouldn't matter because the bottom of the heart will not be able to tell. But the caveat is that when the bottom of the heart beats on its own, it's very, very slow and something that you wouldn't be able to tolerate. And so these patients need a device to pace the heart. And so you are committing them to a pacemaker for the rest of their life. And so it's not ideal, but it's an option. Now, on to antiarrhythmic approaches, meaning strategies to keep patients out of AFib altogether. Some patients who are either very hard to rate control or still experience these symptoms despite having a rate that is controlled can benefit from a strategy to get them out of AFib. This includes being on oral medications or antiarrhythmics, as well as ablation. So what studies have shown, and this is from the late 90s in the New England Journal, is that the most common trigger for AFib is in the pulmonary veins. Now you have 4 pulmonary veins that drain blood out of the lungs into the left upper chamber of the heart. What happens is that you can have impulses that enter the veins that create this chaotic activity that come back into the left upper chamber of the heart and cause AFib. So with ablation, our goal is to basically electrically isolate the veins away from the rest of the heart. The way we do that is we get access in the veins of your leg. We advance catheters or small tubes up the veins into the right upper chamber of the heart, as you can see here. We then use a needle to cross over from the right upper chamber into the left upper chamber, and we advance our catheters over. As I said, you have 4 veins in the heart, and we have a few strategies to ablate around these veins to prevent electrical activity from entering or exiting the heart. Now, we don't interrupt the blood flow. We don't affect the structure of the heart. We just create a thin layer of scar so electrical activity is unable to enter or exit. Now, there have been multiple studies that compare ablation to antiarrhythmics to controls. And they've all shown that patients who receive ablation have a high freedom from AF at 1 year. But it's dependent on if they are in that initial group where they only have short amounts of AFib, or if they're in those later groups when they're in AFib all the time. And as you can see, the freedom from AFib actually improves if you're on a combination of antiarrhythmic drugs as well as ablation. So this is also a common strategy. So the current climate now revolves around interchanging the use of antiarrhythmic drugs and ablation. It's not as stepwise as you think. There are some patients who may do well with antiarrhythmics initially, others who do well with ablation or with a combination of both. It's important to make sure that the patient understands that there is no cure. It's not uncommon that they need another or even a third ablation. Actually, what studies have shown is that the more ablation you have, the better outcomes you have. Because if you can imagine, with any scar, if you get a cut on your arm, it tends to shrink over time. And so when we ablate around the veins, that can also shrink over time, which can allow these electrical impulses to enter and exit the veins again. So we've done ablations 2-3 times even, and it's actually allowed for improved outcomes. Another thing that's very important to note is that you should not use ablation on patients who cannot be on anticoagulation, because the highest risk of a thrombus or a clot to form in the heart is the initial month when they're back in a normal heart rhythm, which means if they're in AFib and you get them out of AFib and they're unable to be on an anticoagulant, then they're going to get a clot, they're going to have a stroke, and you're in big trouble. So you want to avoid that. And then 2, it shouldn't be used to try to get patients off of anticoagulation. that said there's no cure for AFib. There's a high percentage of recurrence despite everything that's done. And so just because you're not an AFib now, it doesn't mean you may not be in a year or two. And so if they can be on an anticoagulant, then they need to stay on an anticoagulant. And that's one of the most common questions I get in clinic. Can I come off of an anticoagulant? And it's no, unless there's a clear reason. The answer is always no. So there are also non-pulmonary vein triggers that may need ablation as well, meaning areas that are not the pulmonary veins that can also induce AFib. One common one is called atrial flutter, which is basically an arrhythmia that occurs in the right upper chamber of the heart that can also induce AFib. And so when we go and ablate, there are not only the veins that we target, in some patients, we also target other areas as well. This is an example of the back wall of the left upper chamber of the heart. So you can see here, this is your left upper chamber of the heart. You have the 4 veins here, and this is the back wall. And in some patients, you can get these electrical impulses that start in the back wall as well. And so it may require that we ablate around the veins as well as the back wall to attempt to isolate the entire thing together. This is actually a case we did a few days ago of a patient, and you can see here on the left, his veins were already isolated for the most part from a case that he had done in the past, but he had all this activity. The purple, the green, the blue is all atrial activity. And then so what we did is we made a line of ablation above and below the back wall, and you see the red means that there's no active activity there. And so we're able to isolate that. So early ablation, what we've learned, is crucial to maintain a normal heart rhythm. The more AFib you have as time passes, you're likely to go from having AFib every now and then to having it more often to having it all the time. When that happens, the role of the pulmonary vein tends to go down, meaning that isolating the veins alone are not going to get these patients having AFib. And so you create a scenario where other areas of the left upper chamber of the heart are not causing AFib, and it becomes impossible to ablate all these areas. And so it becomes very hard to get them out of AFib. Another form of ablation we do is called cryoablation, which is using a balloon that enters each vein through which a cold gas goes through to freeze around the entry of the vein. So instead of using the heat energy to ablate at every point around the vein, this is kind of a one-shot ablation around the antrum of the vein to freeze. There have been multiple trials comparing the two, using RF energy and using cryoablation. And what they've shown is that there is no difference in event-free survival or safety. So if you ever get asked, what type should I have done, it's basically the same, and it's very much dependent on the user. There are physicians who do one more commonly than the other, but at the end of the day, it's basically the same. There are also many newer technologies that are coming into play, and it's very exciting. They're being clinically tested now, and the field of AF ablation is growing at a very fast pace. So there have been a few recent studies that have started to shift the paradigm as we move towards trying to keep people out of AFib and trying to control the rate alone. But as I said, it's very dependent on the patient. And then additionally, as ablation technology improves and efficacy improves, it's beginning to take the forefront over anti-arrhythmic therapy as well. The CASTLE AF trial showed that in patients who have heart failure and AF, there's a decreased risk of death after ablation. in the Cabana trial, it showed an improvement in all-cause mortality and cardiovascular outcomes with ablation as compared to antiarrhythmics. And in the East trial that just came out in the last year or so, showed that the early control of AFib leads to improved outcomes as compared to waiting. So again, as I said, the field is improving. It's very exciting. So what are the risk factors of AFib? This is something that I think is the most important slide in the talk, because regardless of what you use in terms of oral medications or other therapies, if these risk factors are not controlled, you're not going to get patients out of AFib. Coronary artery disease, hypertension, obesity, COPD, diabetes, and sleep apnea. This is very critical that you speak to your patients and tell them that the onus is on them. It's to be able to get them out of AFib, they have to take care of themselves. So in terms of weight management and exercise, I think initial target of over 10% is a good target, with the goal of trying to get to a BMI of under 27. Avoid large increases and decreases in weight in a short amount of time. It's going to cause strain on the heart. Exercise is extremely important, at least half an hour a day, 3 to 4 days a week. In terms of high cholesterol, initially try to improve exercise and diet. Start them on a statin if they need a statin. I've been trying to convince, especially Indian patients, that being on a medication is not a bad thing. I mean, obviously, if you don't need to be on one, then you shouldn't be on one. But being on a medication, if you need to be, can be something that can improve the quality and the duration of your life. So treat them. If they have high cholesterol, treat them. Obstructive sleep apnea is one of the most important things. If you can imagine, if you're hypoxic at night, every night, the strain that it can have on the heart. So if they have untreated sleep apnea, you can throw every antiarrhythmic, do every type of ablation, but you're not going to get them out of AFib. So you must treat sleep apnea. And then, as we all know, hypertension and diabetes are also very, very important. The ARREST AF trial looked at patients who either got ablation and or antiarrhythmic therapy, along with strict modification of these factors, and showed a significant improvement in survival when it's combined with these improvements. So an integrated approach is very important to allow for the best outcome in these patients. So the AFib incidence prevalence is continuing to grow, and it will continue to grow. It's connected to weight, high blood pressure, diabetes, and these are things that are going to continue to worsen, at least at this point, with our changes in diet and lack of exercise, and things being extremely convenient has an impact on our hearts. Oral anticoagulation is the most important treatment strategy in AFib. A stroke is something that can be life-altering, life-changing, and it's something that you want to try to avoid at all costs. Having these new or novel oral anticoagulation agents makes this a lot easier, and it should be the first line in most patients. As I said, if they have a mechanical valve or if they have a stenosis that caused the AFib, then it should be Coumadin, at least for now. The management of AFib, including the use of ablation, needs to be tailored to each specific patient. As I said, trying to control the rate is a great strategy in some, it's not in others. It's important that the patient and the person who is managing the patient have a clear understanding of the goals of care. as I said, and it's very important, there is no cure for AFib, and there should be no expectation of a cure for AFib. We can only try to reduce the burden as much as possible. Ablation of AFib should not be done with the goal of trying to stop anticoagulation. We have to stay on anticoagulation. And then making sure to modify these comorbid conditions like sleep apnea, hypertension, high cholesterol, weight, appears to play a very important role in the management of AFib. Now here are a couple of home monitors that patients can use that I think is extremely helpful. One of the things that we give to patients is called a Zeo patch, which is basically a little monitor that's almost like a sticker that goes right here on the chest. It used to be even 10 years ago that you would have to have all these wires all over you. You don't have to do that anymore. It's very easy. And now we have things that the patient can get themselves, an Apple Watch or this cardio monitor, which is very easy and actually very accurate. And so in patients who want to monitor whether or not they have AFib, this is a great option. There are also a few tools that you can use to help stratify patients for anticoagulation. ACC has a few applications that you can download. There's the anticoagulant application and the clinical app. This allows you just to go input for the CHADS 2 mass score, and it gives you an answer in terms of if they should be on anticoagulation, what kind of anticoagulation, if they have a high risk of bleeding or not. Helps make things a little bit streamlined, a little bit easier. And you can always go, I think a great resource is Up to Date, quick resource if you want to go up and look at these scores. And then the HRS site has an excellent guide for AFib. If you need something to give to your patient to help explain everything that we have talked about today, definitely use this. I'm sorry, say it again?
The LDL,
Yeah.
Yes.
Yes. So this is probably from a European paper. I think it's from the European Cardiology Society. But yeah, we don't use this. Yeah. So so it depends on the patient. If they have a history of coronary artery disease or a carotid disease or peripheral artery disease, the goal is to get an LDL of 100 or below. If they don't have that, then you can go up to 170 or so. And so it's the same guidelines that we use when we decide whether or not to start statins in patients who don't have AFib as well. Yeah. Oh, great.
The first time itself was like 4 hours.
Yeah.
So the ablation procedure itself is 4 hours, almost the first ablation. And I know that you guys are mapping it really thoroughly, but you said the second and the third ablation will be necessary for a lot of patients.
Yeah.
Yes. So when the patient comes the third time, the first time is okay. The third time already the patient has low EF right now, like you said, and there's a higher risk of pericardial tachycardia because you're going to ablate the more scar tissue. Why are you not able to get it at the first time? Because you do have a technology person who's helping you inside the map is really thoroughly. And I'm not sure why you have to keep getting these patients. Now, 2 days ago, I had a patient went 3 times for this ablation procedure, came to the OR, and giving conversion on this patient. I know you didn't mention that, but
Yeah.
I think it's good. He was only 53 years old.
Yeah.
So we had to go ahead and do it, but his tissues are very, very thin out.
Yeah.
And we have to do complete monitoring for the recovery.
Right.
Can you explain why?
Yes, absolutely. Yeah, no, it's a great question. So it's a great question. So she's asking, why do we have to go back in multiple times? Why aren't we able to get everything the first time? And it's a few reasons. One, you can have these connections occur again. So when we ablate around the veins, either with RF energy or with the cryoballoon, we're creating a thin layer of scar. And initially, there's a lot of inflammation in the veins. And so the veins may seem isolated because of that inflammation with that scar. But over time, they can be as early as a few weeks even, you can see that AFib come back. And it's because there are basically small channels that are opening as the scar begins to shrink. So that's usually the most common ones. The other issue is that we isolate the veins, but they go back into AFib because they develop other triggers of AFib. For example, the back wall or other types of atrial arrhythmias. And so we have to go back in and ablate those. Like the example that I showed you with the case we did last week was the veins were isolated, but we had AFib recurrence, and so we had to go back and isolate the back wall as well. The third reason is that when we ablate, we can also create the potential for atypical atrial flutters. And so what I mean by that is that you can create scar. We are creating scar in the heart. And when arrhythmias occur, it's possible to travel around that scar. So these are arrhythmias that occur because of the ablation itself. And so we have to go back in and create lines of block within the left upper chamber of the heart to prevent that electrical activity from being able to go around that scar. Generally speaking, the redo ablations are not as long as the initial ablations. I think, and with the improvement in technology, it's amazing. Just the mentors that I worked with, they would say, AFibs would take all day. They would do one AFib a day. Now we're doing 3, even 4 AFibs a day. 2 hours, and I think the speed and the efficacy will continue to improve as well.
It is the normal anticoagulant. You can see that they use aspirin too.
Yeah.
When would you use aspirin and why?
Yeah, that's an excellent question. So he asked if they're on an oral anticoagulant and also on aspirin, or why would they also be on aspirin? So we have some patients who, despite being on an oral anticoagulant and being compliant with it, they still have thrombus in the heart. And this becomes extremely challenging. It's usually patients who have specific types of heart disease like amyloidosis, HCM, where they're at higher risk of having thrombus, even if they're on an oral anticoagulant. So usually the first thing we do is also put them on aspirin. Another option is to take them off of the novel oral anticoagulant and actually try Coumadin. And we may go to a higher INR goal. Instead of 2 to 3, we'll go to 3 to 4. But a lot of these patients who still are unable to improve the clot burden, and then you can become very trapped in terms of how to manage these patients. But usually it's because they have a thrombus, even though they're on oral anticoagulant.
Another question from Sadhapan.
Excellent presentation. I'm
Thank
very proud that AFib, but it's amount of money spent in the healthcare system in America. AFib is not a new disease. It's been there for, I would say, from the time when the human beings were there. But nowadays we are treating it in a different way. But clearly from Brigham, Harvard Medical School, the trial showed medical management with drugs and anticoagulation is the only way to make the people to live long and with without stroke. That's an upfront trial, which is there with 25 to 30,000 patients. But nowadays we are using this catheter, and I do convergent ablation once a month. And every time when we do a heart surgery, we do a convergent as well as concomitant ablation. So everything we are doing, and we are trying to close the appendage with the Watchman, Lariat, and I use a clip that I do the complete occlusion. Still, it is a disease which is there and it is uncontrollable, as you said. And the highest amount of money spent, like 15 to 20 billion dollars spent on in the United States. So I just want to come up with one more thing is, when we use these newer anticoagulation, they are the gold standard now, even for valvular heart disease, because we only use the tissue valves. We don't use mechanical valve anymore, which is out of market. So newer anticoagulation is the best one, along with aspirin. Aspirin is used because it is shown to be the best antiplatelet agent so far, and also reduce the coronary artery disease. So anybody about 50 years old, whether they have AFib or not, they should take aspirin. And when they have AFib, this newer anticoagulation definitely shown to improve the survival and do the live long. So excellent presentation, very nice.
Thank you.
People who cannot take anticoagulation for various other reasons, could you comment on the dual antiplatelet agents?
So that's a great question. So in patients who cannot tolerate oral anticoagulation, I think the first thing to understand is the reason why. I think a lot of the times we see patients who have a history of a GI bleed, and then now they are labeled as unable to tolerate anticoagulation, and then we implant a occlusion device, for example. But a lot of the times over time, they are actually able to tolerate it. So I think it's important that clinically we make sure that they are truly unable to tolerate oral anticoagulation, and that amount of people is actually very, very, very small. In terms of antiplatelet therapy for AFib, independently of occlusion device, it has not been shown to be comparable to a oral anticoagulant. Now, if you have a low CHADS2-VASc score, there is an argument to be made if you have a score of 1 that you can put a patient on aspirin. The risk of having a stroke at 1 year with a score of 1 is under 1%. In patients who are unable to tolerate anticoagulation and they get a occlusion device, these patients actually for the initial 6 weeks have to be on an oral anticoagulant, because there's a risk of thrombus that can form on the occlusion device. And so it's actually a catch-22. If you have anyone who has an absolute contraindication, at least for right now, to be on an oral anticoagulant, they in general cannot get an occlusion device. Now, long term, after the initial 6 weeks, we start them on DACT, usually aspirin and Plavix for at least 6 months, and then with the goal to get them on one agent. But as it's been said, the gold standard, if they're able to tolerate, is a oral anticoagulant. Yeah.
Dr. Mayer, pediatrician from Canada. Just a quick question. Role of aspirin. For 50 selling, but not for those. You must take aspirin. But as a senior physician, endocrinologist in our place, this is 80. He basically stopped anticoagulant aspirin, especially because of the risk of cerebrovascular accidents. And I read the article, still reported. Aspirin should be taken away unless indicated by a cardiologist or a value physician. I want your comments.
Yeah. So this is true. There were a few studies in the New England Journal of Medicine that came out in the last 2 or 3 years, showing that age alone should not be a independent instigator of taking aspirin. So it used to be, the thought process was, is anyone over a certain age should be on aspirin to prevent a risk of coronary disease or to prevent coronary
it can affect your individual practices as well. I do want to acknowledge that the slides and data are from the advisory board and SG2. They're healthcare consulting companies that we use, and so some of the information is from there. I'm sorry, going back up, this is kind of the outline of some of the things that I want to cover. Again, the effects of the pandemic on volume for health systems and long-term outlook for providers. Financial performance for hospitals, labor shortages, site of care shifts, disruptive industry changes, and growth in overall payer mix to governmental funding sources in the long term. So we'll start with, how the pandemic has, in summary, really suppressed near-term volume growth for health systems. For many of you that have been in hospitals, you may have heard someone show you some data on volumes. But the long-term outlook on provider demand remains strong due to heightened disease prevalence, the baby boomers, and overall population growth. So if you can see this chart here, and I'll go over it in a second, right? Yeah, okay, great. So, key point, again, is health system volumes improved across all categories compared to 2020, especially for emergency department visits. But some hospital-based surgeries and visits remain well below pre-pandemic levels. So if you look at this slide, what you see are estimated health system volume performance. For reference, of course, 2019 was pre-pandemic. We'll think about that as a baseline. 2020, the beginning of the pandemic. And all of you, the practice know that we've had to make significant changes during the pandemic, whether it was, reshaping how we do work in our hospitals, creating more ICU space, and also having to shut down elective procedures so we can accommodate the sicker patients. And we actually pulled providers and healthcare workers from the outpatient setting of care for our inpatients. In 2021, we had a better understanding and we were better prepared, but did have significant surges of COVID volume in our hospitals. So what we see here is that health system volume improved across. So again, here's 2021 versus 2020, and then 2021 versus a baseline of 19. So if you look at what's happened since 2020 to 2021, the volumes have actually increased, and this gives you the range of volume changes for inpatient admissions, ER visits, surgeries, outpatient surgeries, and outpatient visits. But when you compare to a baseline of 2019, most of that volume hasn't come back, except for outpatient surgeries, right? We've had significant decline in inpatient surgeries and ER visits. This is, again, across the country. And our outpatient visits are roughly about the same. And we'll go over some of the reasons in the coming up slides. Let's see what else I want to say about this. So the non-hospital surgeries actually recovered stronger than hospital-based surgeries, partly because patients had put off their elective procedures during the pandemic. They were afraid to come to the hospital, concerned about the potential spread of COVID. And so, but we're starting to catch up on all that as patients have come back, right? Outpatient office visit utilization was a mixed bag, as I said, variable performance based on practice and staffing levels. And we're going to talk about that a little bit, which has been a big issue, throughput and embrace of telehealth. Providers continue to face similar challenges to volume growth in 2022 as they did in 21. Again, the complexity of patients along with persistent COVID-19 admissions and post-acute care bottlenecks are leading to prolonged length of stay in inpatient units and prohibiting the return of some non-COVID-19 patient volume. So we go to the next slide. This shows a 5-year outlook and by some categories. So inpatient volume will decline slightly while outpatient services grow at a strong rate. If you look at a 5-year volume forecast. So the left side of the graph shows inpatient volume, and basically there's going to be a decline over the next 5 years. And by 2031, we do expect a 0.6% increase compared to where we are today. Inpatient surgical volumes will decline even faster by 2.8% by 2026 due to continued shifts to outpatient settings. And I'll cover that a little bit later in some slides, the trends that are causing that. Labor shortage and care avoidance will continue to suppress volumes in the near term, but longer term demand remains strong due to a sicker and aging population. For outpatient services, which you see on this side, Health systems can expect strong volume growth. Volume is expected to grow by 7.3% by 2026 and 14.9% by 2031. That's obviously in stark contrast to the inpatient growth. So the key areas that are expected to grow are cardiovascular. You see them both here by 8-12%, and spine and orthopedic service lines will grow by over 10% by 2026. Psychiatry will grow over 18%. That's got the expected largest growth of any specialty in the same period due to greater rates of psychological distress, a trend that was obviously exacerbated at the pandemic. Most revenue growth will come from outpatient service expansion in the future. So the next trend, revenue performance for hospitals in 2021. Margins continue to be pressured by elevated costs and looming price cuts. Hospital margins are slim. This was interesting to me as I went into administration. This is really about 3% is the average margin for hospitals across the country. It's razor thin, and this is what most hospitals work with. So margins have recovered from their lowest point in 2020, but will still be slim despite strong revenue performance. So what helped here go from 2020 to 2021? Obviously, this is during the beginning of the pandemic, and then this is during the surges of the pandemic. It was the CARES Act. They included $100 billion in aid for providers and was a vital lifeline to hospitals and health systems early in the pandemic. But that funding has now run dry. As you guys know, Senate, Congress didn't approve further funding for many pandemic-related operations. The median operating margin stood at just 2.5% at the end of 2021. That's an increase of 45% compared to 2020, but was still 3.8% lower than the baseline, as I said. Margins are this thin despite revenue increases compared to the 2019 baseline. Inpatient revenue actually increased by 10% and outpatient revenue increased by 11%. Now, obviously that's contradictory because the margins are lower if the revenues are increasing, but that's primarily due to the significant increases in expenses for health systems. We're going to see that on this slide. Expenses are driving healthcare margins down. Health systems expenses have risen across nearly all categories, including labor, which is the #1 cost for any health system, is the labor force. And then the second is usually prescription drugs, is the second highest cost for any health system. And then you got supply chain and capital expenses. So COVID-19 led to several temporary and one-time cost increases. For example, health systems, as I talked about earlier, had to set up new spaces for COVID treatment, increase ICU capacity, negative airflow, and other isolation spaces, which are obviously significant capital expenditures. And many of you have experienced this, whether you see it in the hospital or in your own practices. We have to use premium labor, and this isn't unique to healthcare. This is happening across the industry. Across the country. But we have to use premium labor to adequately staff during surge periods. Significant sign-on and retention bonuses required given shortages brought on by early retirements, higher reports of burnout, and highly inflated salary expectations. For example, nurses on average earn $70 an hour. Just during November to February time, and into March, we were paying over $200 per hour for nursing. And similarly, pharmacy techs that average $24 an hour, we're getting $95 an hour. So, this is significant, right? And it's across the board if you look at each position that are in your hospitals and clinics. And also that frontline entry-level employee has been very difficult to get because they do have other options, whether it's Amazon, for example, for our EDS workers, and food and nutrition workers have been very hard to get. And then global supply chain issues, well, we don't need to talk about that. That's happening across the board. But that does impact our supplies on the medical side, including drugs. And, interestingly, prescription drugs, the vast majority actually come from China and India. So obviously any supply chain issues do affect us. Let's see, the other reason for prescription drug costs is obviously new care treatments, monoclonal antibodies, bevacizumab, for example, for COVID treatment, and antiviral agents such as remdesivir and Paxlovid. Actually, on average, drug expenses go up 6 to 9% every year for every health system. So when I say it's a big cost, it's a continuous rising cost. Whereas prior to this year, labor had gone up by 2 to 3%. But now again, everything is completely different. Expenses are likely to remain elevated in 2022, and costs will not be temporary or one-time expenses. Overall, labor costs, like I said, will remain higher due to a tight labor market and burnout. Supply chain costs will remain elevated due to price growth and general geopolitical risks. Prescription drugs costs, we talked about that, and health systems will need to make the capital investments needed to enable telehealth and remote work and to expand access to care. Those are 3 key components for health systems to be successful going into the future. Again, capital investments as always. Many didn't make capital investments over the last couple of years due to some of the issues we talked about. You got to catch up. And then telehealth is becoming a big part of medicine. I'll show you where that's worked the best. And then remote work. Many employees are demanding remote work. And you think it'd be odd in healthcare for employees to work remote, especially for example, in the hospital setting. But there are plenty of opportunities. There's a lot of leadership positions, and even when I think about pharmacy now, there's a lot of pharmacists that verify every order that comes through the hospital and or verify med recs. They can work from home. And there's several positions throughout like that in a hospital, and they have options to work elsewhere. So labor shortages, again, not unique to our industry, are more severe in hospitals. So when we look at hospitals and ambulatory care settings, it's more severe in hospitals, and due to inflated salary offerings, but not from non-hospital firms, as I mentioned earlier. So this shows, okay, good. See that slide? This shows kind of what some of the dilemmas are. Hospital employment is still down nearly 2% compared to pre-pandemic levels. Now remember, that's at a time that as the volumes are starting to go up, as I showed you, but we're still understaffed. And this is due to early retirement, competition for staff by traveling nurse firms, ambulatory facilities, and sectors entirely outside of healthcare. It'll be difficult to recover volumes with less staff, especially with current levels of staff burnout. But increasing investments in the workforce may also be untenable, maybe an untenable solution given current margins. On top of elevated premium labor costs, market competitive salaries and hiring bonuses have reached new heights, and we talked about that. Hospitals may struggle to compete for staff in this environment. Ambulatory care providers, I did hear that, and I talked to Ramo earlier, we do have some that practice traditional medicine, including being in the ambulatory care setting. But, when I talk to nurses or NPs in the hospital, they want to go to these settings. It's 9 to 5, weekends, and it's a much better lifestyle than being in a hospital, and you get paid roughly the same. Ambulatory, as the hospital employment numbers have gone down, the ambulatory care sector has been able to return and exceed 2.5% higher on their staffing. And the other thing with nursing, we've all known there's a nursing shortage, but if you talk to any nurse, it's much easier. They want to be travel nurses, and not, you used to have to go to different states to travel. Now you can literally go from hospital to hospital in the same area. And we have that all the time. They become a traveling nurse, and we're short, so is the hospital across the street. And they literally go back and forth and get paid close to $200 an hour. Get a lot of nodding heads. It's a crazy world, but that's what we're living in, and that's what we have to compete with. We do have to revisit remote work policies, as I said, salaries, benefits, and employee engagement initiatives that'll help us remain competitive. So, this next trend is actually significant. We've seen site of care shift, right? We talked about inpatient surgeries going down. It's not that the surgeries are going down, it's where are they happening? They're starting to shift to the outpatient setting. And it's because of regulatory pushes, as well as peer steerage and new competitors in the ambulatory space. There's 3 shifts that are significant. It's high complexity procedures, the ambulatory surgical centers, which are obviously high reimbursements for the hospitals, and office-based labs, and physician visits to telehealth and medical admissions to the home. So a lot of these hospitals at home kind of concept. So, okay, there we go. So, you know, this data is really interesting. So there's up to a third of hospital outpatient, up to a third of current volume can move to the hospital outpatient setting, right? So non-hospital sites, they're going to compete for volume. So shifts from the hospital to freestanding settings of care are the most impactful to health systems, given the potential for revenue loss, of course. This is, you know, not surprisingly, hospitals make most of their money on procedures, not from inpatient admissions. As a matter of fact, almost all Medicare inpatient admissions we lose money on. It's the insured patients and the procedures. So the most consequential service at risk of shift are concentrated in orthopedics and cardiovascular service line. PCIs, for example, are starting to go outpatient, low risk PCIs, of course, not acute STEMIs. Total knee and hip arthroplasties, we've seen a significant shift in that. Spinal fusion, and again, more complex than most procedures performed in ambulatory settings today. They also account for a large share of hospital revenues, as I said. At our hospital, you know, when the pandemic started, we were doing, we do about 1,500 or 1,400 total joint procedures a year. We were doing only 20% of those as outpatient. We shifted that to 80%. That means people are getting their knees and hips replaced and leaving 6 hours later to home with home health care, right? So that's the trend. So if we can do that at the hospital, then, you know, somebody goes, well, why can't I do that in an ambulatory surgical center? And so that, again, that's what's growing a lot of this, and there's safe ways to do it. We use the Mako robot, which actually is less invasive, and we seem to get better outcomes. But again, there's just a lot of great technology to help with this, and patients do better than staying in the hospital a day or two, which is surprising. Our ambulatory patients consistently do better when we discharge them to home. I think it's just primarily because they move more. Ambulatory surgical centers and office-based labs are the primary entities gaining market share for high priority hospital procedures. But, you know, physician comfort and safety concerns still persist, and those will keep some of those procedures from shifting to these ambulatory sites, at least for a while. But again, there's factors like CMS covered procedures, payer steerage tactics, and patient demand for convenient access outside of the hospital also drives a lot of these. I think, you know, on this list, it's not surprising. Many of these we've seen. PCI by us hasn't happened, but I have heard other areas where, again, cardiologists are starting to do more procedures, not just peripheral vascular, but again, coronary. And then lap choles, again, not around us, but starting to happen. But the other things I think most people have seen. The other, you know, piece is telemedicine. It's really taken off during the pandemic for safety reasons, and and the other reason is it was covered by payers. This technology's been there for a long time, but you weren't getting paid for it for those visits. That totally changed the landscape because CMS started to reimburse it, and then the insurance had to follow. So it was obviously also well received by patients in some specialties. Although when we started off with the pandemic, we started with several areas as televisits so we can reduce our clinic volume, so we could use some of those resources on the hospital side. That patients, we realized, didn't really like telehealth. And you know, my parents are here, and they'll tell you that they don't really enjoy that. You know, it's not the same as seeing a doctor, and I completely get it. But behavioral health, it's been very well received, and also post-surgical visits. You know, any surgery you have, you got to, you know, check your scar and all that. So you can have quicker assessment, and then when you need your stitches removed, if you do, then you go in. And then immediate care has been very well done too. And I think those are good areas. It really makes sense. You know, there's some data from Aetna and CVS. Pre-pandemic, in 2019, they supported 10,000 virtual mental health visits. Last year, they supported 10 million virtual mental health visits. So that's kind of where things are headed. And again, but I think it's very specialty specific. Key for continued growth is, of course, payment. That's not a surprise, but there is uncertainty as some of these funds, again, run dry. How are we going to approach this? The other interesting area is home health, right? We talk, when we think about home health, we think about rehab. You send a patient home, they get rehab in whatever form. But more and more, there's this concept of hospital at home. It is literally taking what we do at the hospital and providing that service at home. Believe it or not, it's lower overhead to send a nurse, some equipment, and all of that. And you know, as opposed to keeping a inpatient room. Again, why would that be? Because if you're moving people around, it seems like a lot of work. But because, like I just said, procedures pay better in the hospital. Hospitals are at higher capacity. I would want my low-risk CHF patient probably to be at home if they can get good care. And these are the trials that are happening, and we're seeing that it does work well. The patient comes to the emergency room, they get that, I'll use CHF, you get diuresed, and you know, so I don't know, they're like 88, 87% O2 sat, you diurese them well, and you know, they're going to need continued diuresis in the hospital, but we can start to do that at home, give IV Lasix, you know, Q2, I'm sorry, Q8, Q12 hours, whatever it is, and monitor that. And, you know, Dr. Narayan presented some telehealth capabilities with patches, et cetera. It's the same concept. You can set up a lot of these, set it up Bluetooth, and just kind of watch from another setting in the hospital. So the number of home-based care episodes and telehealth visits grows rapidly, with major reimbursement decisions still undecided. So this is another one where reimbursement is going to help decide how this moves. Despite the potential, actual shifts to the home will be limited by several factors. Obviously, distance between hospital and patient, you want to make sure that they're safe, and if something happens, they can come right back. Caregiver, you need caregiver support at home. We do send nurses or pharmacists, but it's not 24/7. Availability of home-based clinical and non-clinical staff, as I said, and accessibility and cost of necessary technologies. And also, not surprisingly, physician reluctance. The other thing that's more prevalent is home infusions. Many patients, we don't have to keep them in the hospital anymore. If you have osteomyelitis, you could be discharged home for the rest of your antibiotic therapy. You know, they used to come to at home. The home healthcare agency comes with a nurse and then applies it. We did that during COVID for several monoclonal antibodies.
technologically advanced, and it is indirectly proportional to the physical activity and the number of calories that we spend. So the more advanced technology, the decrease the calorie expenditure in most cases. So the other second picture that I have here is wealth more than health. So most of us over here, we came from India. We wanted a better lifestyle. We wanted to settle down sooner. We earn money over here. But we lose the concept of, okay, after settling down, after getting money, then what is going to happen with our health? So if you think about it, my YouTube channel, my demographics is between 35 to 45 years of age, because only then somebody would have told you that, okay, you have blood pressure, okay, you have sugar, okay, you have diabetes, right? So the wake-up call comes a little bit later. And the main reason is because we are prioritizing wealth over health, and there is no point in having $10 million in the bank account if you don't know whose name it is under. Right? So that is what is happening recently. And this is a very serious problem. And, the problem that I'm facing, I'm thinking the other major problem is easy food access, right? So before we used to hunt down food, we used to work for food, but now, right, if you turn right, there is food, left, there is food, up, there is food, bottom, there is food. The problem with the bottom food is if you look down, you can see. See, that's, that's the problem. Abdominal obesity, and I want you to take this as an exercise. I want you to go to your room tonight, tomorrow morning, call Zero, the operator, ask them to give you an inch tape and measure your belly button first thing in the morning and send the NSNA group of WhatsApp, not by me. If your centimeter, if your numbers are more than 100 in men, congratulations, you have passed the test of being overweight, and it is being tailor-made for you. And if you're a woman, if the waist circumference is more than 90 centimeters, you meet the criteria for obesity. So this is especially true for Tamilians, and there has been research shows that, I'm not even kidding, Chettiar community, they have done some research on that we are genetically predisposed to heart disease to start with. How many of you have a family member who has a heart attack or a stent placed? Very common, right? So actually, when I go back to India, oh, stent, so it is very, very common. So it's a serious problem. If Christopher Columbus was here today, he will go around our belly to see whether it is flat or round. So it's how bad it is. And so why should we change now? Okay, sorry, that is not an answer. Especially if you have family, if you have young kids, you don't have a choice. You need to live until they become 18 years of age. If not, you don't have a family. Who agrees with this concept? Right? You should be consciously responsible for your family around. And after they become 18 and when they are on their own, then you can do whatever you want. So the problem is about not quantity of life. We are not planning to live for like 100 years, but we want to live, even if we live for 5 years, we don't want to be in a hospital. We don't want to be connected to a ventilator. We don't want to be on a dialysis machine. We want a good quality of life. That is what the whole process is. So, how many of you have seen this WhatsApp message of GoFundMe program for like young people dying between 35 to 40 years of age? Even yesterday, I got a message, please send, please donate as much as possible to this wonderful family. And if you look deep into it, the damage didn't happen at that time. The damage happened 10 years ago. Right? But the 10 years ago, we were so busy, we want to settle down, we want to focus on wealth. Unfortunately, the health is being taken a hit. So it is getting pretty big. Basically, in the laptop. Okay, so reasons for obesity is, so it's a very, very simple equation. How many of you are like software engineers here? Good, super. You don't need this equation. It is pretty easy, right? You don't have to compute a if-then statement for this, right? If there are calories more than you spend out, the excess calories is going to store as fat, thinking that your body will need it later when you need some energy when you don't have food. So that is how a body is tuned, right? So I consider this mechanism, this concept, especially for a Chettiar community where we keep in the Patram and Kalyanatha Veli Patram. Veli Patram Akana concept of in the Veli Patrata, number of generation, other generation use Panikuanga, print to Nambikilla, Pakiron, Kadisi, use Panama. If you have excess calories, your body thinks that you will be using it somehow, but that never happens because thanks to Swiggy and Zomato. Okay. So, and also calorie out is obviously it is much less. So methods for weight loss, as soon as you think about weight loss, what do you guys do? Let me ask Meenaj. Meenaj, your experience you have patients. When you say weight loss, what do they do usually? They skip meals. Okay, what else you guys have tried before? Exercise, good, super. Diet and exercise. Okay. After exercise, first time we go to gym. We go to gym or we try lifting heavy weights, including the pressure cooker in the kitchen. But the key concept is next time when somebody says that you want weight lose what a gym sign stop பண்ணி ஜிம்முக்கு கொடுக்குற $20 நீங்க வாங்கிக்கிட்டு அவங்களுக்கு வந்து low carb diet வந்து சமைச்சு கொடுங்க. Okay, so 80% is diet, only 20% is weight loss, exercise. So we need to focus on diet more. So அதான் கண்ணாப்பினா diet வந்துச்சு, calorie restricted diet இருக்கு, keto diet இருக்கு, carnivore diet, paleo diet, desserts with breakfast diet. Have you ever heard of the diet? Desserts with breakfast diet. The concept is, if you have an idli or a dosa, you can have a kadala mithai along with it. And the concept is that, okay, it will quench your hunger, it will satisfy your cravings later. But the problem is, my friend Saran Kumar also eats a jalebi at lunch, thinking that that will satisfy the cravings for dinner. And that cycle never ends, it keeps on going. That's what the desserts with breakfast diet is. So Mediterranean diet, there are multiple studies showing that Mediterranean diet is the beautiful diet, rich fiber, rich in everything as much as possible. So when I said that to one of my patients, he was like, it is very expensive to go to Mediterranean area and then follow the diet. How about my Marina Beach? So, it doesn't work that way. So weight loss, as I said, only 20% of your work is for weight loss is exercise. So when you think about weight loss, everybody is so busy, right? Everybody is so busy, except for these 3 days, but in general, everybody is so busy. So you need to figure out whatever time you have, you should have the best bang for the buck, right? So we know how to put things together. We know how to put the numbers together. So we want the best investment. We want the best returns. We want Tesla. We don't want mutual funds. We want Tesla, right? So you have to figure out what time that you have, that you put in, so you get the maximum results. So don't waste too much time on the exercise if your diet is not good. So focus on the diet first. The second one is, if you are okay with the diet, then you proceed with the exercise. So walking, everybody starts with walking, and then running. What everybody do for running? They buy a treadmill, right? They buy a treadmill, exactly. And then the reason for buying treadmill is they don't have time to run outside, and they end up buying a treadmill, but they spend more time in finding the treadmill under the pile of clothes, right? The start button of the treadmill is not working anymore. So, and then the third one is strength training. Strength training is the mother of all exercises. Strength training is the best bang of your buck. But when I was actually in medical college, in PhD, I know that you go to gym only for 2 reasons. Either you want to become a bodybuilder or you want to impress girls. These are the 2 things that I know. I didn't go to the gym anyways. But the concept is everybody needs strength training, especially women. Women need strength training to the maximum because hormonal imbalance causes osteoporosis, your bone density will be decreased. So you guys are at increased risk more than us, but how many of, especially from an Indian community, you don't see that many women out there in gym, not in California, but in general. So the point is that you have to include strength training, which is not being talked about at all. So before doing strength training, you need to have a little bit of an education. If not, the next day we'll be walking like the Allu Arjun song, Pushpa song, if you know what I'm talking about. Okay. So, so this is another thing. So, okay, you guys decide about weight loss. Okay, so you said, okay, that's fine. I took care of my diet. I'm going to Mediterranean diet. The second thing is weight loss. Exercise. So you said, okay, well, I'm going to do exercise. The concept is you need to exert yourself. All right. The only walking that we did during COVID time is from upstairs to downstairs. Right. So if you walk outside, you need to exert yourself to your maximum heart rate. I've seen people walking around. I know my friend and his wife walking around. My friend walks like, the wife says, it's so very, very casual, right? So the heart rate is never increased. And it is just a waste of time. Again, look at the concept of having the bang for the buck. Everybody is busy. You only have 30 minutes. There is no point in walking around. Just do high intensity interval training or strength training or something like that. That is going to give you results even faster so that you will be even more motivated. So how do you calculate this? Everybody has a maximal heart rate, right? So how do you calculate this? This is 220 minus age. For example, I am 16 years old. So, okay, so I'm 38 years old. So 220 minus 38 is 182. It should be at least 70% of the heart rate. So it comes around 127 beats per minute. How many of you have an Apple Watch here? Good. Have you ever looked into heart rate? Good, super. Maybe in the presentation, and the slide among So if you look at the heart rate, it has to be around like 127, and it has to be for 30 minutes or 5 days a week. So you have a small leeway. Either you do like 30 minutes, 5 days a week every day, or you could just do like 150 minutes of like 2.5 hours at a stretch. But you need to do 150 minutes of some kind of exercise, right? But your heart rate should be around 127. Okay, it has to be around 120. I mean, for me. You have to calculate your heart rate, and 70% of the heart rate you need to make sure that you maximize. If not, basically you will still get some results, but it will not be maximized. So again, bang for the buck. You have to invest in the product that gives you the maximum returns. All right. So I'm just giving you some tips and tricks. Okay. So as soon as we decide, so what we do running. We sign up for the gym. The biggest thing that I did, I was obese before, like 5 years ago. I was 100 kilos. Just think about it, 220 pounds. And I'm a medical doctor. And I tell my patient, lose weight. And he looks at me like, really? Are you serious? And how many of you have seen, I shouldn't say this, but in my opinion, physicians should be like really more health conscious. They have to be fit before recommending to other people. So, we need to make sure that we walk the talk that we do, right? So, so that's what hit me that, okay, something has to be done. So what I did, I signed up for the gym. Who has heard about Crunch Fitness? Good, perfect. Because why do I join that gym? Because that is the cheapest gym. Right? That is $10 per month, correct? $10 per month. All right. The good thing is they make so much business out of it because they pay the $10 and nobody comes. Right? And that guy, when I signed up, he said that, sir, $10 at Sacramento location. But if you pay $20, even if you go to Bay Area, you'll work out in the Crunch location even there. Now on a day. Now Sacramento ke varamatena. Huh? Sign up for gym. Okay. Eat salad. Green tea. How many of you using green tea for weight loss? Good, super. Take it from me. The only way that the green tea is going to help you lose weight is you actually physically go to the mountain and pick up green tea leaves for yourself. That is the only way that's going to work out. Okay, it has rich in antioxidants and all those things. Oh, quinoa rice. How many of you changed to quinoa? Good, super, Oma. Quinoa, thinking that you lose weight, but did you lose weight? Good, super. Because it's not the quinoa, it is the amount of quinoa. It's the amount of quinoa. one cup of rice வந்து boiled rice தான் வந்து 100 calories. இவங்க வந்து boil பண்றதுக்கு முன்னாடியே 1 cup of rice வந்து 100 calories calculate பண்ணுவாங்க. And then millet dosa is very popular. Okay, how many of you have used millet dosa before? Good, super. The main reason that people don't lose weight on millet dosa is because of yes, many dosas. Nobody can stop with one. Lays chips க்கு பதிலா இதா போட்டுருக்கோம். Dosa gram. Nobody can stop with one. அப்புறம் ரெண்டாவது main problem with dosa. Oil. Oil எவ்வளவு தூரம் நீங்க தோசையில ஊத்துறீங்களோ அவ்வளவு தூரம் உங்க ஆயில் வந்து கொஞ்சமா பண்ணிட்டே இருக்கு. Okay, so why do you think all this is not how many of you have heard this story that I tried this, I tried that, nothing is working, right? Yeah, everybody has gone through, including me. So I was 100 kilos. The first thing I did was join the gym. அப்புறம் ஒரு வாரம் வந்து நடக்க முடியல. அப்புறம் then I said, okay, I'm going to eat salads. அவ்வளவுதான். Lunch, breakfast lunch மட்டும் தான் முடியும். Dinner வந்து அடுத்து சாப்பிடுவேன் chicken biryani. So it is the reason is the main reason is it's not sustainable, right? It's not sustainable. So think about it. We develop belly fat not overnight, right? So Rome was not built in a day, neither did our belly fat, right? It took so much time. It slowly got accumulated. Each and every time when you eat an unhealthy food at an unhealthy time, you start accumulating belly fat. So to get a sustainable result, to get a maximum outcome of your input, it needs to be sustainable. It cannot be lose fat in 7 days. Drink this, lose fat in 4 hours. Who have seen that video on YouTube? Right? That YouTube video is 1 million views. Now, 1,000 views. So, and then I have another technique of losing belly fat in 4 seconds. You know how? We know that when we are taking a group NSNA picture, everybody will use that technique. Okay, so that's how I came across time restricted feeding. So I didn't know about this, to be honest. I didn't know about this at all. The camera. Okay. So I was like, okay, so so then I had a colleague, who was a primary care physician, and then she said, okay, why don't you enroll in this time restricted feeding program? So I did. And then I started noticing significant results. So let's see how this works. So before that, when I was obese, there were 2 reasons for it. One is whenever I started to lose weight, my mom was like, "Enna ipdi elchite poren." அதுக்கப்புறம் வந்து இந்தியால அமெரிக்கால இருந்து இந்தியா போனோம்னா வந்து என் ஒய்ஃபை பார்த்து என்ன பண்ணி சாப்பாடு போட மாட்டேங்கிறேன் முடிஞ்சிச்சு. So my mom thinks that the more plumpier you are, the better doctor you are. If she wants to, if she is the one who's going to train the MBBS curriculum, she will do 5 years of MBBS to be a doctor and 1 year to look like a doctor, so that they eat more. Okay. And the other thing is my wife starts cooking things and then says, "Kuppela poda poren, ungalukku venuma." Right? So nadandhirukka illaya? Yaar kai konnuva? Correct, exactly. Okay, so how does this thing work, right? So this is circadian rhythm. So when I said that to one of my friends, he was like, "Idu vandu A.R. போட்ட மியூசிக்கா அப்படினாரு. அந்த rhythm இல்ல, அது வேற rhythm. This circadian rhythm vandu, it is a constant sleep wake cycle that is happening in our body. So everybody knows that we wake up in the morning, we go to bed at night, and then we wake up again in the morning. So there has to be a cycle. இல்லாட்டி வந்து எப்ப தூங்குறோம் எப்ப எழுந்திருக்கிறோம் நம்ம தெரியாம தூங்கிட்டு இருப்போம். So this is all regulated by the circadian rhythm. So every hormone follows a circadian rhythm, believe it or not. You என்னன்னா எடுத்துக்கங்க, thyroid hormone, insulin hormone, glucagon, growth hormone, whatever hormone, including complan, whatever thing that you eat, it has a circadian rhythm. A particular time la correcta vandu peak agum, particular time la it will subside down. It is like a musical orchestra. It is beautifully orchestrated, and it is all done by this nucleus called suprachiasmatic nucleus, SCN. இது தம்மாந்துண்டு ரெண்டு சீடு மாதிரி பிரெயினுக்குள்ள இருந்துகிட்டு என்ன வேலை பார்த்துருக்காங்கன்னா So what happens in research studies is, in mice, they took one of these seats out. So there are two seats. Okay, ரெண்டு seat இருக்கு. ரெட்டை இலை மாதிரி ரெண்டு இலை இருக்கு brainல. அதுல ஒரு இலைய வந்து, if you remove it, that mice did not sleep for 7 days at a stretch. If you remove both the seats, then that mice did not sleep for 2 weeks at a stretch. So if you don't have this rhythm very orchestrated, and that is where the problem starts. As I said, it is a well-coordinated circus. So it's a ringmaster is the suprachiasmatic nucleus, and the performer, if a performer jumps, the other performer has to be there to receive him. If not, he falls down and the damage happens, right? The only problem is the damage is not evident when we do that to our body. The damage is very evident if there is a circus. So this is a pictorial representation of the two important hormones that I love about, and I want to educate you about that as well: insulin and melatonin. So insulin, as you see, it peaks up around daytime and then dies down at night. And the melatonin is a hormone that makes you sleep. So we sleep. When do we sleep the most? When we grew up during childhood. Huh?
Early morning.
Early morning. I was expecting a lecture class. During lectures, we start to sleep. Huh? Okay. One of the main reasons is darkness. So you remember when I was 10th படிக்கிறப்ப வந்து அப்பதான் PowerPoint வந்துச்சு, introduce PowerPoint, right? So when they had a PowerPoint, they need to make sure that there is no light. If not, it will not be very good quality. So they closed all the screens, and the only person that was awake was the person who was actually talking. Everybody else was asleep, because as soon as darkness hits, your melatonin starts stimulating, right? So look at this. Time of the day is x-axis. Okay, I hope you can see that. Okay, so time of the day is x-axis. So 8 a.m., 12 p.m., 4 p.m., 8 p.m. You're good. You're all active. We're all active. And in the red one is the plasma, the blood level of melatonin. Look how it starts slowly at 8:30, peaks up around like 2 a.m., 3 a.m., and then dies down at 8 a.m. Right? But when do we go to sleep? We go to sleep at 2 a.m. or 1 a.m. or 12 p.m. where the melatonin is supposed to be at peak levels, right? So when we sleep at 12, then or 11, what happens is the melatonin is getting delayed, right? So it will delay after 2-3 hours, and then it will start slowly picking up. But by the time it peaks up, what happens? The sun rises. So once the sun rises, no matter how much darkness you create in your place, you are going to see some kind of brightness, and that single stimulation is good enough for melatonin to be disappearing on the body. Right? So you will need at least 7 hours of quality sleep, and this is what is happening if you have any problems with sleep disorders. The two small glands I talked about is right here, suprachiasmatic nucleus. This is called the master clock, like the Vijay in Master movie. So how do we know this works? So we did research on mice. So what we did was we took 2 groups of mice. One group, we said we will make the mice drink and eat the same amount of calories. So let's say that we give them 1 pizza, 1 chicken biryani, and 1 dosa. All right, for 2 mice at the same for the same content. But the only difference is we did it by change in time. We gave first mice from 8 a.m. to 8 p.m. and the second mice we gave from 8 p.m. to 8 a.m. So which mice do you think is the left one? 8 a.m. to 8 p.m. Look at the right one. It started having, so we found that there is significant amount of obesity, significant amount of blood pressure within 3 months, just 3 months, with this increased weight gain, with this night food. Okay, so I'm a gastroenterologist. I'm a doctor. I might not look one, but I am. So I deal with fatty liver all the time, right? So how many of you have heard fatty liver? Good, super. So And the orange color shirt, but every name, how do you know about fatty liver? So what happens is, you must have seen this, India, you go for something else, you have abdominal pain. You get an ultrasound for something else, and then the ultrasound says fatty liver, and you go to your doctor, and then the doctor says fatty liver இருக்குப்பா அது ஒண்ணும் பிரச்சனை இல்ல அதுவா சரியா போயிடும் அப்படிட்டு அதுவா எப்படி சரியா போகும் நம்மளா வளர்த்தத எப்படி அதுவா சரியா போகும் so we get this all the time so if you look at the liver it's supposed to be pink throughout but look at all those white globules those are all fat globules what we are eating. Right, so this is exactly how I tell my Indian patients is those white fat globules are nothing but the gulab jamun that you ate last night. Right, so what happens is the gulab jamun goes all the way from the belly, goes all the way into your liver, and then gets deposited over there. Right, so jamun போட்ட fat ஜாமீன்ல கூட எடுக்க முடியாது அந்த அளவுக்கு வந்து ஸ்டாக் ஆயிடும். So once it gets slowly gets accumulated in the liver, what happens at one point of time, there will be no pink tissue at all. It will be all fat globules. It will be completely replaced by the liver. And then it will end up in cirrhosis. Your liver will not work. And that is where you will need a new liver transplantation, right? So, in movies, we see people vomiting blood, like a hero vomiting blood on the Kamal Hassan. What do people think? Because of, what does he have? People think it's blood cancer, right? They spit blood, they think it's blood cancer. It's not blood cancer. It's liver failure. Only people with liver failure vomit blood because of the dilated esophageal veins that we see. So, he's basically, he's in liver failure, he's also in love failure, right? So he's in love failure and liver failure, but he not only needs a new lover, he also needs a new liver, right? So you need to, that is what the fatty liver concept is. Okay, so moving forward, so this is what we did for all my fatty liver patients. So they come here and then we say, we do this time restricted feeding, and then 3 months later, their scar tissue disappears, their numbers come down, they lose weight, they are happy 90% of the time. And the clinical research experience, these are all like 3 studies that I was involved in partly, and we have proven that this method works. So consistent weight loss. So the problem is consistency, right? So all this is one of the picture that I put because I need to calm you guys down before looking into the real picture, which is this. This is my personal experience. I told you this, right? Because I was 100 kilos before. So 2006, I was like 23 years old and I was like 145.65 kilos. These are my obese pictures. I was not like this in 2006. I was very lean. So 10 years, same thing I said that before, right? So, I wanted to settle down. So I kept on studying. I didn't even know about what is calorie. I didn't even know about what is exercise. I said, okay, we will figure all that out after reaching residency, after getting a job, after getting settled out. So slowly, all the belly fat gets settled as well. I was from 145, went up to 200. And then I started doing all this diet exercises between 2016 to 2018. Nothing worked. These are on the left still my obese pictures. So from 2019 to 2022, that is where actually 2018 2019. So this is what happened with me. The first thing that I did was, okay, so nothing is working for me because it is not sustainable. I'm going to the gym for 2 weeks and I'm all done, and then I'm not able to sustain the diet. So, but I think this time restricted feeding is something sustainable. I can do it. My doctor is asking me not to eat after 8 p.m. Yes, I can make it work. So I made that work. I lost 15, initially it was 15 pounds in like 3-4 months. It was very rapid. So once you see that change, you get really motivated. You'll be like, oh, okay, so this is working, because you're so frustrated, you're so disappointed that this is whatever you do is not working. So the first time that you see something, you'll be like, oh wow, this is good. So then you get motivated, then you do strength training and you do more about it. You learn more about it. So weight loss is not the only benefit, right? Only benefit. It has mental health, sleep quality, acid reflux, you have more energy, you have good bacteria in your small intestine. This is like a Diwali gift hamper package. In addition to the fireworks, you'll also get the sweets, you'll also get the lecture, and also get the neighbor's free advice. Everything is a complete package with this timer secretary. So again, we talked about why does this work? Because of the hormonal control. And I want to take some time to explain about insulin. How many of you have heard about insulin or have used insulin before for you or your family member? Good. So have you ever seen how insulin is? So it's a small, it's an injection, right? So you take insulin and you inject yourself. So the same kind of stimulation, like what you are injecting, happens each and every time that you eat, no matter what. Even when you are cooking food, how many of you are tasting the food before when cooking? Yeah, good. Even that small, actually, I also cook. And even that small sip or small little bit of ingredient is good enough to stimulate insulin, because your insulin is like your katapa. It's so loyal to you, right? So it will tell you it will do what you tell it to do, what you ask it to do. So if you want, okay, I'm eating something, insulin, please get secreted, please digest this, it will do for you, right? So whenever you eat, the insulin level spikes, right? But insulin is also a human being, almost, right? It needs some rest as well. You cannot keep on beating insulin. It is not like your husband. It will have some problem. When secreted after 6 p.m., it is of very poor quality, very poor quality, right? So I say that insulin is like an IT employee, government employee. It works only from 9 a.m. to 5 p.m. If you make it work like a government employee, then you will get emails like, please find attachments, and there will be no attachments. The quality of work will decrease, right? So whenever there is a quality of work is decreased with the insulin, what happens with the excess energy? It gets converted into fat, because it thinks that you will need that eventually, which we will never need. That is the problem. That is the main problem. The second hormone I want you to know is growth hormone, right? Growth hormone. So growth hormone secretes right after. Let's put growth hormone and melatonin together. Okay, so that both these hormones get secreted after insulin dies down at 6 or 7 p.m. But whenever insulin wakes up, these two will come down. இவங்க ரெண்டு பேர் வந்து ஒரு மாதிரி விரோதிகள் மாதிரி, பாட்சா ஆண்டனி மாதிரி ரெண்டு பேர் யாராவது ஒருத்தர் இருக்க முடியும். இன்சுலின் இல்லாட்டி growth hormone ரெண்டு யாராவது ஒருத்தர் இருக்க முடியும். So when insulin dies down, growth hormone comes up. So growth hormone, what does is it repairs all the damage that you have done in the body. Each and every time you eat some food, the gastric acid is secreted by the cells lining the stomach. So each and every time the cells gets damaged, and then it digests the food to help you out. And what repairs these cells? The growth hormone. The growth hormone comes in the night, like Batman, like Gotham. Gotham, like Gotham City, and it starts repairing these cells. And so that next day, you will get a new cell, so that your insulin is get rested, and your insulin will get more active, and it will be like 100% quality. So that is why when you don't have any repair cells, when your cells are of good quality, you don't develop cancer. And I guarantee you this, if you follow this method of not disturbing your growth hormone for at least 12 hours, I can guarantee you that there will be no cancer. There are multiple research supporting it. Like there's a concept called autophagy, and it is absolutely important for your growth hormone to repair all the cells. Think about it, right? So your cells are repaired. You need 12 hours to get it repaired. It's like your car tire. You have to give some time for the mechanic to repair it. If not, what happens? You are driving the car with a punctured tire, and the tire is going to get flat out on you pretty soon. So that is what is happening in the growth hormone. So how does this rhythm work? So this time period has to be at least 12 hours. Okay, you need 12 hours of repair. So for example, your first bite in the morning, let's say that it is at 8 a.m. You can eat whatever you want initially until 8 p.m. And once 8 p.m. is done, that's it. Just water, just plain water. You don't add anything else. And after that, that is the time where your growth hormone actually comes in and repairs for you. It actually works for you. This is like your katapa again. Please make use of it, right? So why should we waste the good quality of the growth hormone? So when this rhythm doesn't work, right? When this rhythm doesn't work and you are eating unhealthy food at unwanted time, what happens is insulin puts fat, converts excess energy. The first sign is belly fat. And that is why I want you guys to measure your waist circumference to be aware of what's going on. So how to maximize these results? So if you can start with 12 hours, 8 a.m. to 8 p.m. and then you decrease the eating window to 8 hours. For example, 10 a.m. to 6 p.m. That is where the research shows that you have the maximal results. You have the maximal results. It is going to take some time. My friend is like, I'm getting hungry. I said, drink water at night. If you drink water, I need to go to the bathroom very often. I said, that's okay. If you have to go to the bathroom for 6 weeks, it is totally okay. You're not going to create any Tesla within like 2 weeks. Within 6 weeks, your body will get accustomed to it. Your body will get adapted to it. This will be your new normal. First 6 weeks, துன்பப்பட்டு துயரப்பட்டு கஷ்டப்பட்டு ரொம்ப கஷ்டமா இருக்கும். அப்புறம் அதே பழகிடும். 6 weeks மட்டும் பல்ல கடிச்சு நீங்க பண்ணிட்டீங்க அப்படின்னா this will be like a very good habit to you. And sleep is the other important thing I always talk about. Melatonin, we talked about this briefly. How many of you have a good quality sleep of 7 hours in this thing? Good. Oh, that's more than what I thought. So for example, I came from California last night, a red-eye flight. I have only like 2 hours of sleep today. And then I don't have time to catch up usually, and usually busy medical practitioners, also busy software engineers. The earliest thing that we compromise, the first thing that we compromise on is sleep. It's okay, we'll wake up early. And we keep damaging our body slowly that we don't understand the importance of it. So again, remember, you need 12 hours of growth hormone. Growth hormone works better when you are asleep or when you are taking rest. So at least 7 hours of good quality sleep. சில பேர் சொல்லுவாங்க நான் மத்தியானம் 2 மணி நேரம் தூங்கிட்டு சாயங்காலம் 5 மணி நேரம் பண்றேன். அதெல்லாம் பண்ணலாம். ஒரே படியா 7 hours பண்ணுங்க. Okay, so the next one is 7 hours of quality sleep, and hormone should be 100% quality the next day. So water intake, we talked about this. Your body is composed of 70% of water. So basically, if you keep on drinking water, your hormones is going to work automatically. So for men, at least 3 liters of water. Has anybody actually quantified how much amount of water you have taken? Good, super. Usually we just drink water when we are thirsty, but try to quantify it and you'll be amazed that how low we have been taking. So try to hit the 3 liters per day mark as much as possible. And there is a difference between hunger and thirst. When you follow this method, you are going to feel hungry, right? But most of the times it is actually thirst and not hunger. There is a thin line between hunger and thirst, and if you choose food over water, the thin line will become a thick line around your waist. Okay, so think about it. All right, fiber. I can't emphasize more. The most important nutrient that you need is fiber. When you eat fiber, you get good bacteria in your small intestine, and that increases your immunity to the core. So basically, when everybody was drinking Kabasura Kudini, I was just drinking our plain old Taire, yogurt, all those things which has lots of fiber in it, including green leafy vegetables. So fiber, it has been shown to maintain the circadian rhythm as well. And the biggest thing is it keeps you full for a long time, even with like small doses. Fiber is like Mani Ratnam movie dialogue. Only 2 sentences, but the message is conveyed. Same thing, only 2 grams of fiber, you will be keep full. So you need to at least have 25 grams of fiber per day. right? So 25 grams of fiber. So you have to start looking into what you're eating and how much amount of fiber is there in each and every food that you're eating. My friend is like, I have geofiber. Will that work? That doesn't work. I hope you understand what geofiber is. Okay. Metamucil is one of the things that we use all the time. If you're not able to reach 25 grams of fiber, we supplement with this Metamucil Metamucil supplement, which gives you 3 grams of fiber, only if you're not able to reach 25 grams of fiber through your diet. So, protein. So, this is one of our favorite topic. So, every food that we eat has carbs, proteins, and fat, right? It's like a music. It's like an orchestra. So, it's like Ilayaraja, A.R. Rahman, and Anirudh, right? In that, protein is like Ilayaraja. It is very instrumental in your development. And if you don't play that instrument very well, we might have to play the instrument called Sangu pretty soon. Be aware of the protein content in your meal. So, for example, let's say milk has 8 grams of protein, egg has 6 grams of protein. So, for let's say you weigh 70 kilos, we would expect at least 0.8 to 1 gram per kilogram. To make it simple, just 1 gram per kilogram. If you're a 70 kilo patient, you have to take at least 70 grams of protein per day, not for bodybuilding, not for weight loss. That is a maintenance dosage. Just for regular maintenance of your body, you need 0.8 to 1 gram per kilo. So you need to start understanding, start noticing the food label, and then see how much protein that you are taking per each and every food intake that you have. So vegetarians, there is a controversy that vegetarians don't have enough proteins in their diet, which is not true. If you're very conscious of it, you can take vegetarian protein as well, like tofu, lentils, yogurt, green peas, quinoa, and peanut butter. So I'm a big proponent of meditation. How many of you do meditation over here? Good. I'm just a big proponent of it, which means I don't do that regularly. So I'm a very big proponent of it. So, before we used to say, when we grow up, we used to say that don't sit still, do something. Now we are saying that don't do something, sit still. Right? So we are so busy that we need something to calm down, to get the hormonal imbalance corrected. And there will be research showing that if you do meditation, the connection between your cells increases. And maybe the connection between husband and wife will increase as well if you keep on doing it. All right. So meditation, my friend was like, okay, I'm going to combine my diet with meditation by meditating on a medu vadai for like 5 minutes. I said, it's okay. At least start with something. So how do we usually say? 5 minutes a day. It's not a lot. 5 minutes a day. And then you just start doing slowly. And the problem with this meditation is that it's a long-term investment. It's like a mutual fund investment. You don't get the returns right away. You've got to keep at it. You got to take at least 6 weeks daily habit again. Very difficult initially. And then I follow heartfulness meditation. It's a pretty no cost. I mean, they don't do it for money. If you want to check that out, heartfulness meditation. And if you combine that with this time restricted feeding, this is golden. You will never get any chronic diseases, and I can almost assure you. And workout, we talked about this maximal heart rate. And I still remember that when I did this initial running, my heart rate never went up to more than 100. Never went up to more than 100. But I feel very good that I did so many things. So after running a 5-kilometer race, 5-mile race, I ate 5 donuts. I still remember. So all the hard work that I did is gone in like 5 minutes. So please be careful with the diet. One other thing I want to tell you is you can never outrun your diet. Even if you run to the moon, your diet will come back to you. There will be a Nayar Karachaya over there in Mo and say you want chaya. Okay? So you can never outrun your diet no matter how much you run. So the last thing would be strength training. After this presentation, I want you to focus more on strength training. It can be done through yoga, through your body weights, or you can go to an actual gym or start lifting weights because it will build muscle. Muscle will increase your metabolic rate. decrease your calorie expenditure and has been shown to regulate your circadian rhythm. I can't emphasize this strength anymore. And just make sure that you are being advised about how to do that, because to avoid injuries, or else you'll be like an early Arjun Pushpa like me as well. Okay, so this is what I do for my patient. I have labeled this as a new me program for all my patients who come to me. So what I do is I start with them eating window. So let's say that your first coffee is around like 6 a.m. and then you are eating, your last bite is around like 10 p.m. So then we sit with the patient and then say, hey, how can we do this 12 hours? You want to start from 8 a.m. to 8 p.m. Everybody is different, right? So, some people have 2 little kids, 4 and 2-year-old, and they were so busy at medical work. I'm talking about myself. So this one will be a problem based on what is your environmental surrounding is. So I cannot say that 8 a.m. to 8 p.m. for everybody. So you have to individualize yourself and then see what works for you. You start with a 12-hour eating window, and then every week when the patient comes back to me, we sit down, we evaluate the process, and then we decrease that by 15 minutes, 30 minutes based on the motivation and based on whatever response that they had last week. So we keep on doing this until they come down to 8-hour eating window. And most of the time, in my experience, 90% of the people will be able to do that in 6 to 8 weeks. And 8-hour eating window, and that is the maximum. And then I make sure that we go over all the factors that is affecting the quality of sleep. And the main thing is your phone. So the blue light filter, the blue light from your phone gets into your retina and then decreases the melatonin that we talked about, which is trying to peak. So one thing that you can take out of the presentation is don't look at the phone 5 minutes before you go to bed. I keep saying this and I keep doing by myself as well. So it keeps a repetitive habit. It takes time, but that is something that you can do for yourself. So we talked about meditation, we talked about water intake, fiber intake, at least 25 grams of fiber per day, protein intake, at least 1 gram per kilogram per day, workout based on the preference. I tell my patients exactly on the order written over here. This is what we do. Every week we come, the patient comes to me, and then we look into it to see once the first step is maximized, then we go to the second step. We go to the third step. We keep on doing that until the results are achieved. So, this is a wonderful program, and if you're interested, I can tell you as well about this. Because the main reason is one size does not fit all. This is like a movie. You might like the movie Vikram, and you might also like Vikram and movie. Right? Both are entirely different. So you need to taper your requirements and your surroundings and then choose what works for you. Finally, I'll finish by saying this, that our body is golden to us, right? So we have been damaging our body on a regular basis. Who have seen this movie Pasha? Who has seen the interval scene where our superstar Talaivar vachu kambila vachu katti adipangala? And the mother, we have been like damaging our body, all right? And then all of a sudden we have this belly fat, and now we say ulle po aprina pogal. All right, it takes time. So hopefully you get something out of it, and then you have any questions, I'm happy to answer. Thank you.
Any questions, Anna?
Dr. Monica, thank you for your excellent lecture, number one. Number two, could you please, I want to get 2 questions. What is the ideal bite for any person? Are you still using the same good old insurance schedule that has been put in many doctors' office? Number 2 question is, could you please comment about soluble fiber and insoluble fiber?
So Anna, we don't look into body mass index anymore. So especially for Asians, as I said, Southeast Asians, body mass index is good for nothing. So we look only about I've started looking only about the waist circumference these days. So that's number one. Number 2, soluble and insoluble fiber. The insoluble fiber, both the fibers will keep you full. So if you go deep into soluble and insoluble, it's very difficult to find out exactly how much amount that you need. But regardless of whatever the category it is, if your amount is close to 25 grams of fiber per day, that will keep you full, and that is what is required for maintaining the circadian rhythm as well.
Following the diet program of 8 to 8 or whatever time it is, can you skip in a day or two in between, or you should do continuously in the same day?
Yeah, that's the problem. And that's the problem, man. The problem is you do hard work for 5 days, and the weekend comes, the 6th day, the discipline is gone. And we are so used to it that the damage that we have done even for 1 day will completely wipe out the remaining 5 days. Almost like 90%. So you only have 10%. And so by the time the circadian rhythm is getting adapted again, it's going to take a lot of time. That's the problem. That's the problem.
Are there any proven metabolic benefits, meaning insulin resistance and/or impacts on blood pressure? You touched on some of that. Is there evidence to that?
Yes.
Effect, or?
Yes. So the minimum of 12-hour eating window doesn't do that. But when you maximize to 10-hour eating window, we have research. And if you even maximize to 8-hour eating window, blood pressure is going down, thyroid hormones gets regulated. And there have been some studies on infertility getting better in PCOS as well. So it's a budding topic. But these are all the possible clinical research aspects that we have been seeing.
Everybody, amazing. Over 2 years we are practicing vegan diet. Actually, oil if you come to kitchen, there is no oil at all whatsoever. Mandi pannalum oil kediyadu, biryani pannalum, vegetable biryani pannalum oil kediyadu. No oil for pudi paniyar, no oil for dosas, no oil for anything. Oil innadha ponnu mudiyum. So we have saved so much in our fat. And the cholesterol level, the LDL level is only 1. 1. You see anybody? Have you seen anybody with LDL level 1? Is me. Endocrinologist, Dr. May, you must stop your statin anymore. You can't take it. Because LDL is 1, the newborn LDL is 1. And you have that one. That is because no oil in our food. A vegan diet for over 2 years. Love that vegan diet. I must be thankful to my Achi, Malti. She wanted to talk, but she's been nervous about talking. How to make cooking without any oil. That's amazing. Now, Mandi வந்து சாப்பிடுறது ரொம்ப பிடிக்கும். அந்த மண்டி வந்து ஆயில் இருந்தா இப்படி இருக்குமா, அதை விட நல்லா பண்ணாங்க ஆயில் இல்லாம. அதே தான் பிரியாணி, அதே ஸ்மெல், அதே. So I strongly recommend, if you want to reduce your cholesterol, please follow oil-free cooking. நாங்க என்ன பண்ணோம்னா, இந்த vegan diet follow பண்றதுக்கு we had a certified doctors எங்க ஏரியால லீட் பண்றாங்க. He's a surgeon from Florida. The lady from she's the lady from Baltimore. So they're both conducting classes, good health and YouTube. So other than one course with 1,200, we paid money for each, and so much of help for. So I certainly recommend you people to follow this vegan diet. They also do the fasting, so up to 16 hours do fasting every day. Actually, including the vegan. The time restriction. So it's very useful. So we are really evidence for all those things. And now Martin stop and all the metabolic levels are so low. Pressure, cholesterol, sugar, everything has come down. So so much of benefit.
One last question, please.
Hello, Dr. Pam. It's very nice to meet you. The topic that you're talking about is amazing, out of the world. It's very sad that a lot of people don't know about it yet. So we have a group, we're based out of San Francisco. So we have a group of about 50 members who we follow intermittent fasting. So we have minimum, people are doing fasting for minimum 30 hours. 36 is the lowest, I'm saying. So people are going beyond that. So we had a group here as you were speaking. So what would you like to tell me? Like things that you need to watch out beyond 36, 48, 50. So my minimum is 55 hours.
Just water.
So just plain,
water.
yes, plain water fasting. So what is it that we need to, that it's our responsibility to do it safely. It's very nice that people are doing 60 hours, 70 hours. What is it that we need to watch out while we're doing this? So some of the things that we consume while we're doing this kind of prolonged fasting is some ACV, apple cider vinegar, water, and pink salt. So this is for hydration, and otherwise it's just going to be water. Sure. So I want to make sure that I get the message back. If it's okay, I can record while you're speaking to post it in my group. But safety, right? That's something I want to understand.
Sure.
Thank you all, and good thing that the CME program is very good. Please, all of you, make sure that you fill the CME evaluation form and give it to us. We have three forms. Everybody should be filling up 3 forms. A lot of people did 1 or 2. I'm going to be tracking them down and making sure that I get all the 3 forms signed up. Very good. Thank you all. Let me just give this final word of thanks to Dr. Palniappan.
On behalf of NPNA, we want to thank you all for participating today. When we have more programs coming, please join. Thank you.
Yeah, we have to exit.